Welcome, San Joaquin Stanislaus friends. Just give a moment for everyone to connect to audio. Wonderful. All right, welcome to session 7 of CPI. Next slide. You all know the drill. Recording is in progress. Feel free to come on camera so we can see your beautiful faces and also understand if that does not work for you. Next slide. Okay. As a couple reminders, if you can please update your name in Zoom to include your organization, that helps us a lot with data tracking. Now, here's the really important part. Please put in the chat what your least favorite food was as a child, and do you still despise it? For me, it was tomatoes, you all. There was some serious drama on a plane one time with tomatoes with me as a young child. I still don't love tomatoes. Liver, yeah, that's more valid than tomatoes, I feel like. Cucumbers, yep, I'm with you, Alexis. Peas, yep. Oatmeal. Cooked carrots, never dietitian. Oh, that's great. Apricots, okay. Beets, get it.
So John, I'm just disappointed in the apricots. I'm sorry. I just have to come off mute right now. I'm so heartbroken.
Oh,
So heartbroken. And Ashlyn with the tomatoes. I was just describing this amazing Cali pizza I had, and it had tomatoes on there. So now I'm really sad.
No. And as you all can see, we love the chat. We hope you love it too. Please keep comments, feedback coming in the chat. Next slide. If you are new to the collaborative, if you could give us some kind of emoji. It could be a handshake, a thumbs up, a party, hat. Christopher, welcome. Casey, we know you're not new. You've been here before, friend. Newbie, excellent. Welcome, newbie. All right. Welcome, welcome. This is really a space for stakeholders to collaborate, to be identifying challenges, and to problem solve. Really wanting to make sure that DHCS has the information that they need to ensure that CalAIM is running as smoothly, efficiently as possible, and really working for the people it serves. So appreciate you all being here. We have a shared folder where you can find all materials, and you'll get this slide deck right afterwards to access that. Next slide. All right. Congratulations. We are moving into phase 4, you all. Can I please get a party emoji from everyone? So we've spent time in phase 1 really identifying what are the problems, what are the barriers, what are our shared goals, how are we going to measure progress? We spent time in phase 2 looking at best practices.
Did you see Byron's response?
Hannah, yep, okay. Looking at areas of improvement, and then also outlining what do you as each organization really want to make a commitment around trying on, a change strategy that you want to try on. Phase 3, we looked at solutioning. So testing out these best practices and seeing were there challenges we didn't expect with them, and looking again at your PDSAs. And now we're going to be moving into monitoring, measuring progress, chronicling best practices, barrier busting. You all know we love that phrase, I mean, the phase and the phrase, and making recommendations to improve the system. 1, 2, 3. Barrier busting. Yes, y'all can join the cheesy train over here. Okay, next slide. Session objectives for today. I'm going to receive a high-level update on the recently released ECM and CS statewide policy guidelines. including learning about the new children and youth population of focus. Want to acknowledge that this is a high-level update. The guidance has just recently been released, and so you're going to get a bird's eye view, not all of the details. We're going to plan for an in-person brunch, because who doesn't love brunch? We're going to share with each other where you are in the Plan, Do, Study, Act cycle. And we're going to really study together the tests that you're trying on so we can look at what barriers are being faced in that PDSA. Next slide. All right, so just to break down today's agenda, part 1, we're going to hear DHCS updates. Part 2, you'll hear information about the children and youth population of focus updates. Part 3, planning for party brunch, free food, absolutely. Me too, Casey, I'm there. Part 4, tracking progress. It's really, really critical that we are capturing excellent data on the progress that we're making, the things that we're trying on, to really ensure that the system can work out its wrinkles and kinks. If we aren't really clear on what to recommend and why we're recommending it, that makes that much more difficult. So we'll definitely be giving weight to tracking data. Part 5, barrier busting, and looking at what we're implementing as our test. Next slide. All right, I am going to pass it over to the amazing Alexis.
Hey everyone, I'm so excited to see our familiar friend faces in here as well as a few new faces. Casey, just as you stated, free food, I'm there. Really hoping that when we get to that section, everyone can realize the value of what is being presented just in this like knowledge sharing component that we're going to present on for these next couple of sections, and really wanting to just commune and convene with everyone so that way we can discuss this like in person in like a broader space. So moving into the next slide. During the last session, we shared that DHCS will be writing some statewide policy guidance that was going to address a few of the issues that had been presented during quarters 1 and 2 of CPI. As we have mentioned in the past, we have really been just incredibly intentional about aggregating all of the feedback that you're providing and then uplifting this information not only to the TPA, but to DHCS as well. And so last month, we were able to have a meeting with DHCS in which they provided an update that they were going to update the ECM and the CS policies to reflect 5 core categories. Those categories are standardizing eligibility, streamlining and standardizing referrals and authorizations, expanding the provider network and streamlining payments, strengthening market awareness and improving data exchange. And all of this is being done for the purpose of being able to increase the availability of and utilization of ECM and CS services. So based off of that preliminary update, the policy guides were just re-released, and because they were just released, we wanted to at least give you a high-level update of some of the information that has been provided and updated inside of those guides over the next couple of slides. But we understand that there's a deeper dive that needs to be taken on our part so that way we can communicate all of those fine details. So right now we're going to provide that high level update. When we get to our breakout rooms, we'll be able to discuss any additional questions that you have. So that way over the next couple of weeks, we will come back to everyone just with more fine-tuned details regarding these policy updates. And if we go to the next slide, I will start with some of the updates that came from the Community Supports Policy Guide. I've already dropped the link to this deck inside of the chat for everyone. So if you guys want to hop to approximately slide 10, you'll see the link to that DHCS new CS policy guide that was just released this month. And so I'm going to start off with a couple of contracting updates. So the first update under contracting is that MCPs are being encouraged, strongly encouraged, to contract with organizations that have experience in delivering community support services and have an existing footprint in the communities they serve. So as it pertains to expanding the provider network and really tapping into those organizations that have existing community relations, DHCS is strongly encouraging MCPs to really target those types of organizations. And we understand that this includes non-traditional providers that provide services that historically have not been well integrated into the healthcare system. And this is also in response to feedback that we received that smaller organizations are really struggling to break through to participate in CalAIM. But because those smaller CBOs have deep roots in the community, it really should be a priority for contracting. So DHCS provided this guidance to strongly encourage MCPs to identify and to contract with those non-traditional providers that have that existing community footprint. Importantly, also pertaining to contracting, MCPs do not need to assess CS cost for the purpose of setting rates. So when provider organizations and MCPs are heading into negotiations, the cost of community supports should not be considered as a part of that rate assessment process. The reason why that should not be considered is because DHCS has already determined CS to be cost effective and is ongoingly analyzing those costs. So in previous sessions and very much so throughout 2022, we uplifted the non-binding pricing guidance. And a part of that guidance states that DHCS consulted national experts, including CBOs, on costing. And because of that, because of those assessments, they were able to put forward pricing guidance. And so therefore, like, these rates do not need to be reassessed for cost effectiveness. Moving into the next slide, we also have some updates pertaining to referrals, authorizations, and claims. And Shiva, we can move to the next slide. Thank you so much. These are our three favorite areas, y'all: referrals, authorizations, and claims. And so we have a few updates across each one of these areas. So under the referrals, DHCS expects MCPs to develop the relationships needed to source the majority of the referrals from the community, i.e. from PCPs, from clinical providers, ECM and CS providers, and other community-based referral sources. So hitting the mark there, DHCS expects MCPs to source or to develop the relationships needed to be able to source those referrals. Continuing referrals, MCPs are required to inform members of community supports services. So that also pertains to expanding community awareness, making sure that awareness is being driven so MCPs can communicate appropriately and correctly to their members to inform them of those community supports. We previously heard from some of you, like as participants in CPI, that provider organizations have been feeling as though the onus has been shifted to them with being able to source those referrals and identify those members. And so this is a part of that guidance that MCPs are required to inform members of CS services. Lastly, under referrals, MCPs must consider referral requests from members and on behalf of members. So not just the members themselves, also from individuals in direct connection to the member, such as their families, guardians, and caregivers, ECM providers, CS providers, and other providers and community-based organizations. Moving into authorizations, MCPs must have policies for expediting the authorization of certain CS services for urgent needs. You can find this on page 67 of the DHCS policy guide. So just as a flag, we've included some of the page numbers here where you might need to have like a little bit of deeper insight and you can know exactly where to go. DHCS has also determined that recuperative care, short-term post-hospitalization housing, sobering centers, and medically tailored meals being offered as post-acute care are inherently time sensitive. So because those services are time sensitive, they must also be subjected to expedited authorization. And you can find that also on page 67. Lastly, under auths, MCPs are encouraged to define a process for presumptive authorization. We know in the last session, we actually discussed presumptive authorization as one of those areas that we are encouraging provider organizations to test. So MCPs are encouraged to define a process for presumptive authorization for all CS community supports where a delay could cause harm to the member. And then lastly, moving on to claims, DHS is really just re-emphasizing this information inside of the CS guides, but still thought it was important enough to be highlighted. MCPs must pay 90% of all claim claims within 30 days of receipt. And one of the tests of change during the last session that we uplifted was making sure that the claim or the invoice that's submitted matches the authorization perfectly. So that way there's not a denial because there's inconsistent information. So 90% of all claim claims will be paid within 30 days of receipt. 99% of all claim claims will be paid within 90 days of receipt. And then MCPs are subject to interest payments if failing to meet those standards. These requirements pertain to both invoices and claims submitted by community supports providers. Okay, moving on to the last community supports slide. Just a few quick updates here regarding market awareness. The MCP must include a description of each type of community support and the eligible population on their website. While not required, MCPs are encouraged to take up community supports, which is something that we all know, but the new part is that MCPs providing comparable services that are not considered community supports must now evaluate the feasibility of transitioning those programs to being community supports. So that's now a requirement, that feasibility assessment. Regarding eligibility, beginning on January 1st, MCPs may no longer modify or restrict community supports service definitions. These are anything that pertains to eligibility, geographic limitations, etc. They must provide the service as defined by DHCS because DHCS found that this was reducing how many members could qualify for those services. And then lastly, regarding data sharing, to mitigate administrative burden on community supports, providers who contract with more than one MCP in particular, they may not require community supports providers to utilize their MCP portal for documentation of services, such as notes and care plans. So the portal does not have to be used, an alternative form can be used. So that's everything on CS. And now I will quickly go through ECM. And like I said, I know this is a lot of information to process. This is just a high level overview based on like our initial preliminary review of the policy guides. And then we can take a slightly deeper dive when we get to our breakouts. So moving into the ECM updates, regarding contracting, those updates are pretty much the same. Regarding eligibility, MCPs must use the eligibility criteria set forth by DHCS and cannot impose additional limitations. You'll find that on page 9. MCPs may not withhold authorization until a care plan has been completed. You'll find that on page 96. There are no annual reassessments required for continued authorizations. Instead, the MCP should use a variety of tools to track clinical progress, so that way an annual reassessment won't be required. Regarding referrals, MCPs are responsible once again for proactively identifying members who meet ECM eligibility criteria. The primary mechanism for member identification should be referrals from the community. And then lastly, regarding assignment, some continuity of care rights apply to members even who move outside of the county or switch MCPs. So on page 97, you'll see like some of those continuity of care rights that are applied. And then lastly, MCP should prioritize the assignment of members to a provider that's already known and trusted by said member. Moving on to the next slide. We just want to provide a brief update on the recommended provider types by population of focus. We only have 4 here. So for adults with serious mental health or substance use disorder needs, the recommended provider type is going to be County Department of Behavioral Health or community-based behavioral health and medication-assisted treatment providers. For individuals experiencing homelessness, the recommended provider types are street medicine providers, homeless navigation centers, transitional housing for homeless youth, and transitional housing for homeless youth. For adult nursing facility residents transitioning to the community, provider types are CA community transition lead organizations, affordable housing communities, memory care assisted living and independent living organizations, and the Alzheimer's Association. And then lastly, for adults living in the community and at risk of LTC institutionalization, we have CBAS centers, area agencies on aging, home health agencies, centers for independent living, memory care, assisted living, and independent living orgs, and lastly, the Alzheimer's Association. And then we just have one more slide, guys, for this specific section, DHCS policy guide updates regarding recommended provider types for children and youth. And actually, you know what? I'm going to pause here because we're going to talk more about this in the next section. So Shiva, we can just go to the next slide for office hours. So y'all, as I stated, lots of updates that are inside of this policy guide. This was just a very high level, but we wanted to make sure that we were able to at least introduce you to some of those updates that occurred. We can have a Q&A once we get to our breakout rooms, but most importantly, once we hop into that Q&A, we really want to know like what outstanding questions you have. So as we take that deep dive, we can make sure we're chronicling that. And then also, we know we had to cancel August hours for the month of July. So sorry about that. We are going to pick up with office hours on August 17th. So even if you don't think through any of those questions that you might have today, we're going to prioritize policy updates during that August 17th session. With all of that being said, we're going to transition into the next part of our agenda, and I'm going to pass this over to Eva, one of the coordinators here, and one of the co-leads for the Northeast CPI Collaborative, actually. She's going to provide us with some important information regarding the new ECM population for children and youth.
Thanks, Alexis. Hi, everyone. So in this section, as Alexis mentioned, I'll be providing some more information about the new population of focus, which is children and youth. And as of July 1st, ECM services are now covered for this population of focus. In the deck, you can click into the policy guide for additional details and kind of more details regarding all of the things that we'll be talking about in this section. So one of the things that DHCS provided in this policy guide was more details regarding eligibility for both providers that are going to be serving this population of focus, and then also eligibility for the youth themselves who will be receiving the services. So in terms of provider eligibility, one of the things that DHCS really highlighted was that these providers be community-based, that they have experience providing care to children and youth, and that they have expertise really providing culturally appropriate, intensive, in-person, and timely care management services. That obviously they agree to contract with Medi-Cal, MCPs, but one of the things that DHCS really wanted to highlight is that DHCS does not set ECM provider rates, and that's something that the providers will negotiate directly with the plans themselves. Another piece of information is that providers are able to either submit claims or use a DHCS invoicing template. It's kind of up to the provider and whichever sort of process works best for their capacity. And then also the providers must have a documentation system for care management. We don't have a whole lot of information about what this actually looks like, but it's just important that providers have kind of a system for managing the care management piece. So in terms of eligibility for the youth themselves, generally speaking, all of these sort of eligibility requirements will pertain to youth up to age 21. There is an exception that will come back to kind of towards the bottom of this list, but youth who are involved in the child welfare system or who have a history in the system, they will be eligible up to age 26. But generally speaking, the eligibility requirements involve youth who are experiencing homelessness, who are at risk of avoidable hospitalization or emergency department use, if they're experiencing serious mental health or substance use disorder needs, if they're transitioning from incarceration, if they're enrolled in CCS and California Children's Services or the CCS Whole Child model, they'll generally be receiving most of their services through that program. But if they have additional needs beyond what CCS can provide, they may be eligible under the new population of focus as well. Another eligibility criteria are youth that are diagnosed with an intellectual or developmental disability and meet another eligibility criteria. So IDD in and of itself would not meet the eligibility criteria. They would have to also meet another item on this list. And our understanding of that is that DHCS really wants to bring in providers that address IDD into the landscape as well. As I mentioned, those that are involved in the child welfare system or foster care will be eligible up to age 26, and then also youth who are pregnant or postpartum youth. Next slide, please. So in terms of connecting children and youth to services, DHCS expects MCPs to source most ECM and community supports referrals from the community. And this is particularly true for children and youth with complex needs. They're usually already being served by at least one system, but are less likely to be receiving no services than adults. And ideally, the provider will already be serving the children and youth and can extend its role to become the ECM provider. This feels like something that kind of keeps showing up in the guidance from DHCS because it can be incredibly impactful if that relationship and that trust is already established to then kind of add in the ECM services to what the youth are already receiving from the provider. And because we know that outreach and engagement is really most successful when that trusted relationship has already been established. And then also just want to, clarify that this is also in addition to MCPs still going about sort of their process of proactively identifying members who may benefit from ECM and meet the criteria that we discussed before.
On that client.
Next slide, please.
Oh.
Okay, so what makes this different is that ECM will provide whole child care management above and beyond what has been provided in pre-existing programs. So sort of the metaphor that was used was that ECM will serve as sort of the air traffic control role. So there'll be a single point of accountability. It doesn't mean that they're providing all of the services, but there's a level of understanding of all of the different services that are used by the youth with primary care providers, specialists, et cetera, and also kind of that coordination piece of it as well. And as sort of we mentioned before, the person, organization, or entity that already knows the child best should become that ECM provider because there is that relationship, that trust built. And DHCS also wanted to highlight that ECM does not take away funding from existing care management programs, and other programs care managers can choose to enroll as an ECM provider and receive additional reimbursement from ECM and MCPs. So there was also an example that was provided by DHCS of a young person named Gus, who is 17 years old, who was a member involved in the Health Homes program. And Gus was attending a drop-in youth center with mental health supports and peer partners based in a community clinic. And he was identified given his complex needs and untreated substance use disorder. The youth center referred him to MCP for ECM services, and he was authorized to that clinic. So the clinic ECM staff met him at the youth center to build rapport, strategize a plan with him and his peer partners. And per their plan, ECM was provided at home and in school. So this is an example of really what it can look like. And also kind of building on those, again, relationships that have already been established, and just really kind of harnessing the power that has. Next slide, please. So these are the checklists for MCPs, and we'll just kind of leave this here. You can go back and take a look at it on your own time, reach out to us if you have any questions, and we can show you. You can go to the next slide, please, Shiva. And this is the checklist for prospective ECM providers. So again, you can go through this, look at the resources that are available, and sort of see where this fits into your journey. So we're going to have a poll. And so once we launch that poll, if you could please answer the question, would you consider providing ECM services to children or youth? Yes, if you are currently providing those services, or will absolutely be providing those services, maybe, or still considering. No, if your organization doesn't serve children and youth, or no, if you don't provide ECM services. So we'll give you a minute to fill that out. And then Shiva, you can go ahead and close it whenever it looks like we have a good amount of responses. Okay, that's great. So it looks like 45% of folks are already providing those services or will be. 27 maybe are still considering.
Thank you so much, Eva, and thank you, Alexis. We recognize that was a lot of information, and in our breakout rooms, we're going to have time to really dive in and ask questions. So please take a note of those questions. We don't want them to get lost. We just want to make sure that we have real designated quality time to jump into those. All right, August brunch planning. There will not be puppies at the party unless somebody wants to bring them. I'm all about puppies at a party. So we talked in Q1 and Q2 about how wonderful it would be to have some time together, Casey, to have some time together in person. Also, when we sent out a survey to get more feedback about what dates and times worked, we did get a pretty small number of responses. So just want to dive in today and one, state what the opportunity is, two, provide a poll to check in about dates and interest. Okay. So we would hold it locally in either San Joaquin or Stanislaus County. If there's anyone who would want to host, you are totally welcome to do that. And let me see the chat. Christina, please bring the labs. That would be wonderful. We're looking at a 10 a.m. to 3 p.m. and having really 3 goals for that time together. One is some capacity building training. The second is being responsive to a request and a desire that we heard early on from you all about being an even closer relationship with HealthNet and HPSJ. So to have some real quality time together there. And of course, to do peer relationship building and just to see each other in person. How wonderful. And brunch, of course, will be provided free of charge. And maybe we can even bring milk bones for the pups. Next slide. So a poll is going to pop up. Much thanks to Shiva for doing that. And if you could please fill out which day you would be available to join for brunch. And we're really hoping to get 100% participation on this poll. So first option, Tuesday, September 5th from 10 to 3, Wednesday, September 6th from 10 to 3, or Thursday, September 7th from 10 to 3. We'll get just a moment. All right. Okay, so it looks like the 5th or the 6th is highly preferred. Excellent. Thank you so much. We can go to the next slide. Another poll. What topics are you most interested in for the brunch session? CalAIM funding opportunities, best practices, process improvement tools. For example, the PDSA framework we've been using is an example of a process improvement tool. Health plan coaching. Or if you have another one that you prefer, please click other in the poll and then put the request in the chat for the specific topic. Yes, Casey.
How long are we thinking the brunchin would be? Because I think, at least from my perspective, you have a lot of amazing topics that I would really want to do a much more collaborative and dive into. And I would love to be able to say that a single option for me doesn't work because I want more. I guess we'll just be greedy and say I want to do more while we can, because I think it's always valuable to utilize our time to the best of our ability. So I'm just throwing that out there. If we do a longer lunch where it's like 2 hours and we do, the work through lunch and still continue discussing, if that's even a viable option, maybe we can do 2 options or what everyone else thinks. I don't know if that's just my perspective or if anyone else agrees and thinks that that would be beneficial too.
Thank you, Casey. Right now, we're planning on a 10 a.m. to 3 p.m., which I think gives us enough flexibility to hit a couple agenda items, and then also have some unstructured time for relationship and mingling. Perfect. Okay. All right. So go ahead and fill out the audience poll. For now, just pick one. And if you absolutely have to say more than one, then put your other requests in the chat. But just so for the poll, it doesn't get skewed. Okay. So it looks like funding opportunities and then pretty close between best practices and PDSAs. Very helpful. Next slide. All right. We are ready to move into part 4. And just to put a close on this, we will follow up about dates, arrangements, agenda, all of that. So thank you for the poll information. It's really important. Okay, we are moving to part 4 of the agenda. And we have another poll. What stage of the PDS cycle are you currently in? So the P is for plan. You're in the stage where you're putting together the plan about what you want to test and evaluate. Are you in part 2, which is doing? You're doing the plan, you're doing the thing. Are you in part 3, where you have implemented the plan and now you're really studying, evaluating, reflecting on what works, were there unanticipated barriers? And then stage 4, act. Okay. Or you've completed all the stages, or you have not yet started. No answer is the wrong answer. This is just really helpful for us in again, collecting data and being really clear about where people in the collaborative are. So we know how to best meet you where you're at. Okay, we have lots of people in the planning stage. So we will dig into that more in small groups. And it looks like we did get 100% response, 50, 75, 85, 95, 90. We got more than 100% if I'm doing my math correct. Okay, excellent. Next slide. Okay. And as you think again about the PDSA, so the plan that many of you are working to put together, some have already done, have studied, et cetera, which area are you really focused and committed to improving? The referrals processes, the claims processes, authorizations processes, rate viability, value of investment, health equity, provider education, upfront funding, and justice-involved populations. I'm excited to see this one. Okay. Referrals processes is definitely an area of focus. Looks like also claims and health equity are also very high. Excellent. Thank you so much, everybody. Next slide. All right, part 5, barrier busting. Anybody know a good sticker printer? I think we should have barrier busting stickers at our brunch and little bandanas for the dogs. So we're going to move into breakout room discussion so you all can be in conversation with each other. That's the real juice of the meeting. So we're going to move into 2 breakout rooms. And in both breakout rooms, we're going to be really addressing 2 things. The first is to have time for Q&A about the children and youth population of focus and the DHCS updates. And we will have people from the plans in both groups who will be able to really answer those questions with depth. And then the second is breaking barriers by studying progress. So we'll talk about the plans that you're working on creating, and for those who are past the plan stage, digging into what you're testing and what you're learning. Okay, so we're going to be in 2 evenly split breakout rooms. And we are not, in the first 5 sessions, we split into the pre-contracted group and the contracted group. We're not going to do that today. We're going to mix it up and allow you all to really be in conversation with each other and asking questions to support one another about those bodies of work. Any questions before we move into breakout rooms? And Shiva, because we're evenly split, will people need to pick a room or will you automatically be sent to? Okay.
I believe everyone's automatically being sent to.
Wonderful. See you all in a moment.
Thank you, Shiva. We really want to make sure that we are continuing that investigation, but very importantly, hearing feedback from you all, like on progress to date, what still needs to happen, whether it be at a topical level or at a policy level, and really having a good understanding of where you are with like implementing a test of change. Like we really want to hear feedback on like what you have done based off of participating in this collaborative, just over the past couple of months. And if you haven't yet moved forward with a test of change, like how we can support you, like in being able to just have the supports and resources needed to be able to move forward. So I'm going to go ahead and ask Shiva to screen share for us. And Shiva, if you screen share, can you please start on slide number, I believe, so we can go to the next slide. And yes, part 1 Q&A, let's go to slide 35. So during the first half day session, we provided very high level updates on the policy guides for ECM community supports. We also provided, an overview of the children and youth population of focus that just launched on July 1st. So we just want to spend some time asking, like, what questions do you all have pertaining to the policy updates or pertaining to children and youth? We know as it pertains to the policy guide that we were only able to do a very high level, review of like some of those updates, because I believe in aggregate, there might be approximately maybe 200 pages or so that we were like trying to review. And so we just want to know, like, as we continue this review over the next couple of weeks, what should we be looking out for to make sure that we can answer for you all? And these policy updates were in direct response to what you all have uplifted in CPI. So I know this is a behind the curtains look, but as a facilitator, every single month, we're submitting a report on everything that is discussed within CPI, all of the needs that are flagged, and like at what level the need is needs to be actualized. So is it at the individual organization, is it at the MCP level, or is it at the state level? So we aggregate that feedback every single month and provide it like in the form of a report. And then every single quarter, we do like an exhaustive report based upon like all of the feedback and lessons that are coming out of CPI. So in response to those lessons, those are the policy revisions that DHCS has put forward quite rapidly. Like, you know, I might add, if I'm being honest about that, because I didn't expect policy revision so quickly. So yes, so we just want to hear back from you all what questions you have regarding that guidance, and also any questions that may have arisen regarding. Now, you know, you don't have to raise your hand, Samantha.
Hi, everyone. I'm going to come on screen for my question.
Of course, you
So
know,
I
we
can
love
cover
to
my
see
face in
you.
shame. I forgive me, I came late, and you know, you're in the middle of explaining the children's, I think it was Eva explaining the new population of focus. And I just had a question, because we decided not to go with that yet, even though we work with youth in some of our programs, you know, so we're familiar with the population, but for CalAIM, we were like, you know, we're still trying to absorb the one population and get it right with the one population we have. But my question was, we have been getting referrals. Before this opened up, we were getting referrals for children. So we're working, I can count on two hands the number of families we have that the child is actually the patient, but we're working with the parent, and it hasn't been a problem. We've just accepted them because they referred to us, and you know, we accepted them and we work with them. But I guess my question is, now that this has opened up with knowledge sharing, because it is a different population and how we deal with them is differently, and it has been a learning process just dealing with that unique little subset for us. And I'm just wondering, in terms of resources, how available is the knowledge of the organizations that did choose us as a population of focus when the MCPs talk to them about that POF? Is that going to be general knowledge, or are they only going to share resources around that POF with those people or with those providers that chose that as a POF? I don't know if I'm making sense. I guess I'm trying to get, will we have the same resources? Because we do have a subset of that population, even though it's not a chosen one, it's not official. Will we have access to resources that would help the children we're already working with?
That is such a good question. So I do want to say that my response is going to be a bit nuanced. And I think that, you know, in my true fashion, we should schedule a one-on-one. And the reason why, so first my response, in the months prior, the plans let us know that they are actually prioritizing JI and children and youth populations of focus for certain funding opportunities. And so it's my understanding that if they are prioritizing those providers, it's because they are contracted to provide those services. So, so despite me saying that, it's obviously like other providers still have access to like all of the PATH resources. But it was my understanding that JI and children and youth, because it's coming online right now, that those are going to be some priorities as it pertains to like plans in DHCS, because it's a new POF coming online. So that being said, I hear what you're saying and totally understand. Your organization, you know, recently came online, provide services for a distinct population, still trying to get acclimated to that and put these best practices in place before moving on to the next. So I think that it would be so beneficial for us to touch base to figure out what are the things that you want to consider, like as you're making that decision to become, you know, add on that children and youth population, right? Like as you're making that decision, and then also knowing like what those funding opportunities could look like as like it pertains to cited and IPP, you know? So I think that based off of the outcomes of that conversation, then like we'll have more meat that we can like approach the plans with, so that way you can just make a well-informed decision, which is like the most important, is that well-informed decision.
Okay.
So despite that nuance, like Was that somewhat like helpful?
That was, and it's something to at least go back to my leadership and discuss a little bit more about what we want to think about, and then I'll come to the office hours and discuss more with you guys.
Precisely. And I also want to strongly recommend PDSAing this. So as a plan, like you're trying to determine whether or not like your organization should move forward and when with serving this new population of focus. And because it is new, you don't necessarily have provider organizations that you can reach out to that have had 6 months of like implementation, or 6 months of practice. But in response to the DHCS guidance, those ECM and CS providers are going to be listed on the MCP's websites. So once those are listed, so I would check up on the websites, see which providers have been listed, and also schedule that peer-to-peer one-on-one, because based upon like our experience with between providers, I mean, I'm sorry to put you on blast, John, but even John right now in this space during the last office hours, we received feedback from other peers that feedback received from peers was just invaluable.
Okay.
One thing coming from the state, it's another thing coming from the plans, and it's a total another thing coming from the facilitator, like us as the neutral convener, that it's really trying to get all this information out to everyone. But there's just something really special about that peer-to-peer relationship and really having like an understanding of what this looks like in practice, like not just that theoretical feedback, like what has this looked like on the ground for you all. So, once the websites are updated with those provider organizations that are already contracted for children and youth, I would strongly encourage like PDSing that as well as scheduling that one-on-one.
Perfect. Okay. Thank you for that.
Oh, of course. Yeah, definitely. And yeah, does anyone else have just any questions, thoughts, reflections? And that's another thing, like it doesn't have to be questions solely. We're so welcoming of just any reflections or thoughts that have that may present themselves as it pertains to children and youth, or as it pertains to those DHCS updates as well. All right, so that being said, let me just do a quick check of the chat. We are good. So we can move forward. Let's move into the study part of our breakout room conversation. Let me do a quick time check just to see how much time we're going to be able to have inside of this breakout. So we're going to have about 25 minutes, y'all. And so as we mentioned earlier, during quarter one of this work, no, let me go by phases. During phase one of this work, it was really like problem identification, trying to figure out what the issues are. During the second phase of the work, it was really working with DHCS to uplift statewide policy recommendations, but then also to concurrently identify topical solutions at the organizational level, at the MCP level. And so we want to just quickly review some of the recommendations that we've made thus far as a part of phase 3 solutioning. So as a part of the solutioning phase over the last 2 sessions, we did journey mapping with the entire collaborative in our respective breakout rooms. Whether you're pre-contracted or you're a contracted organization or an organization that is implementing services in partnership with the contracted organization, because not everyone is contracted. So we just want to quickly review some of the tests that were put forward, and we want to hear back from everyone. And like we said, super important. CPI is a funded space where everyone can participate like at no cost. And as a part of that, we just want to make sure that like the information that's being put forward is useful. We have one-on-ones with a lot of the participants where we're able to hear some of that feedback, but we also think it's super important for everyone to hear from each other, for you to be able to share whether or not you have been able to put forward a test, which tests you did put forward, and if not, why, and maybe like what's preventing you, like, is this just not hitting the mark with what your needs are? So for the pre-contracted organizations, not sure if we have anyone that's not yet contracted here. I see, looking forward to learning more about the differences in serving the children and youth population versus adult population, as well as training regarding CPS and privacy. Let's see, that was from James. Before I move forward, James, is it okay if you just lend a little bit of voice to what you just dropped in the chat, just so I can make sure on the back end that we're capturing this accurately and that we have like a really good understanding of like what this ask is, so that way we can make sure we're meeting it.
Sure. Hi, everyone. I just know that a lot of the leadership and, the ops teams are kind of wondering, what the differences are, especially when dealing with the youth population, in terms of privacy, or, when they have, issues or situations that come up, like when the parents should be involved and when parents should not be involved, and CPS and things like that.
Thank you so much, James. So this is exactly why like providing that feedback is so important, because that's definitely a question we had not received yet. So that is super important. So just
due to weather or something else. And so are there other responses or thoughts that folks had to what Casey was saying?
Hold on one second, Teodros. Shiva, I invited you in so you could unmute Nai's cell phone. We're not hosts, so we're unable to do that.
Worries. Sorry about that, Nye. Did that work?
There we go. I see it unmuted.
Can you hear me?
There we go. So sorry.
Sorry.
Shiva.
Okay.
Glad we were able to work.
Thank you.
Sorry about that, guys.
No worries. So, you know what, Casey, I think that's a great idea. Thank you so much for providing.
Sure, I'd have to check.
okay. So what I can do is provide a little bit of information just in case there's a parallel before, I even, send out the subsequent emails that I will send out. So just regarding this data exchange grant, Shiva, can we hop ahead to slide number 42, just so I can provide a high level overview of this data grant? Okay, perfect. So we included this in the additional resources inside of the slide deck that we've shared with everyone. So essentially, because, privacy, HIPAA compliance, all relates to the exchange of data as well. And organizations have uplifted some challenges with being able to accurately or sustainably exchange data based upon either technological requirements, or operational capacity. So there is going to be a second round of data funds available to organizations that sign a DSA. So there's $47 million is going to be available in grants. And this grant is going to provide support with resources to address operational, technical, and technological barriers to data exchange implementation. Even if you were not eligible for TA Marketplace or cited funds, you might be eligible for this DSA grant. So we included the link inside of the deck for you to learn more and apply, and even to ask questions directly to DHCS. So I know even before this grant, you're referencing, there's still training that's needed, around when and how information should be exchanged. But I also think that there's a parallel I'm drawing behind how the information is exchanged as well. So I figured, let me just go ahead and put this grant forward. So what we will do offline, because we don't have a plan yet in our breakout room right now at the moment, is just follow up on what resources are going to be available to support you in identifying how that information should be exchanged, and then also determine if CPI is also a space where other potential children and youth providers could benefit from that information. And you can let me know if I've partially responded to this question correctly, or if you have any follow-up questions as well. Perfect. Okay, thank you so much. So Shiva, we can head back to slide 37. Perfecto. Just regarding some of the tests that we have recommended so far. So for those organizations that are not contracted, I don't think we have anyone in this space that is pre-contracted, but can anyone let me know? Is there anyone that's pre-contracted in this space right now? Doesn't look like it. Perfect. Okay, I didn't think so. So let me just go over to those that are contracted or those that work with contracted entities. So for those organizations, some of the tests that we have put forward are leveraging the MIF to implement presumptive authorization. We discussed that during the last session. So that way, we've heard a lot of feedback about just delays in claims and invoices. So to mediate that delay. We put forward being able to leverage the MIF so that way, once contact is made, you can provide services and move forward with invoicing. We've also put forward for those organizations that are operating at a deficit to assess their rate sustainability, to contact the contracting team specifically to let them know to assess if recontracting is necessary. We've also encouraged organizations to apply for cited and IPP to either increase their workforce or upgrade billing systems. We've also discussed connecting with MCPs to assess bottom-up referrals opportunities and where referrals gaps currently exist, so on and so forth. So moving forward into the next slide, the questions that we really want to focus on for the next 20 minutes are, what test has your organization adopted? So over the past 2 months, essentially, have you determined what plan or what test you want to move forward with? What was the outcome of that test? Was it what you expected? Have you had any barriers based upon putting this plan into action? And for those organizations that have not yet implemented a test, because we're like in month 7 right now, if you haven't implemented a test, we really want to hear from you. Like what's been a barrier to being able to implement a test? And if it's because we haven't addressed your issue specifically, please let us know, because we don't want anyone to fall through the cracks. What was very challenging was that we had so many different needs that presented themselves, and we were able to co-design an aim statement that we all want to reach by the end of this program, which is really surrounding making CalAIM sustainable, but we want to make sure that everyone's needs are being addressed. So I'm going to step back. I'm going to allow everyone to just put forward what test they have been working towards, or what plans they might have, and what issues they might still be facing. And I'm a little surprised because we're usually not this quiet. Is it okay if I just call on someone? Gina, has your organization just identified what specific issue you wanted to work on based off of what's come out of the collaborative? And have you had any issues with being able to put forward a plan?
Hi, Alexis. Yeah, so actually we have not made a lot of progress in this area. Really our participation, our organization is quite large, and I represent a really small portion of that. And in the area where I work, we really were participating in this collaborative to find out more about what CalAIM is all about, find out who our partners would be, or potential partners would be with the health plans and the ECNs and community supports. We've actually gained a lot of information through this, and also over the course of the last few months have learned a little bit more about who those individuals would be. I'm still learning more about who is being contracted and things of that nature. So we haven't quite gotten to this point just yet. Yeah.
So that is so incredibly helpful to hear. And I actually think that I might slightly disagree, because it's wonderful for me to hear that you came to CPI with the purpose of better understanding the provider network, and that you have been able to gain some of that insight as a participating entity in CPI. So I want you to feel that progress, right? You've been able to gain something that may not have had pen to paper put down yet. But that's very helpful for us to hear, because we did hear that from a lot of other providers as well, which was why ourselves and both of the plans, HealthNet, Health Plan, and San Joaquin, really want to have this in-person brunch as well. So that way organizations can better understand who those partners in this space are, and start to put faces to the screen name, right? I think something that's been very challenging. I'm guilty of this as well, because I participate and not only in this collaborative, but others, and so many other workspaces. Sometimes we multitask in these meetings as well. Whereas if we have an in-person convening, we'll actually have a space to commit to one another. So super glad to hear that you came for the purposes of networking, and that it's been a little fruitful.
It has been, yes. So that's why we appreciate this opportunity. It's just we, like I said, we're not contracted at this point in time, but still exploring. I don't know that we would necessarily be a contracted provider, but definitely want to make sure that we're connecting with our partners.
Perfect. No, that's super helpful. Thank you so much.
Thanks.
And actually, because we do have time, we have about 15 or so minutes left. I think I would just like to maybe just go around the screen if that's okay. And Andrea, I kind of feel like you just volunteered.
Yeah, I just wanted to kind of mimic what Gina said. We were kind of what is the word I'm looking for? Encouraged by the California WIC Association for all the 84 local WIC agencies across the state of California to come to the table at these meetings. And again, I don't think, just like Gina, Community Medical Centers is over 1,000 employees, and I am one program. Although I think I am a large program, but I'm one program within this large organization that does so much. And I'm here really representing the WIC program, not even necessarily community medical centers. And I know CMC, like we are participating in community supports, like with our SUD program, but I am in no way involved in any of those conversations. I'm representing our WIC program, wanting to have a seat, and I was excited to.
Oh no, I'm sorry. Is it me, everyone? It's a little frozen. Oh, Andrea, I'm so sorry. There you are.
Am I back?
Frozen for a second. Yes, you're
Okay.
back.
The first couple meetings that I attended, I felt like kind of focused on homelessness, and I felt not connected in any to those programs. And so I'm excited to kind of hear more about the children and youth programs, because that is the population that I serve, and how WIC can support those programs. I'm not really looking for funding or getting into a contract, but I want to have a better relationship with our 2 health plans. I want to make sure that every child and every pregnant woman in San Joaquin County gets a referral to the WIC program. And how can we facilitate that? So I'm really interested in like referral processes and making sure that those families are referred to the WIC program. And also a large part of what we do at CMC at our WIC program is also refer out to other programs. And so just getting a better understanding as to, what these programs do. And I feel like we do. I mean, I've worked in San Joaquin County for 15 years now, so I know many of the programs, and I am kind of sad to see them not here. I feel like there was 25 of us on the call over 2 counties, and so many amazing programs that we all serve. So interested to see who is currently at the table and how we can best partner with them. And because of vacations and other things, I've missed the last couple of meetings. And so I feel a little bit behind in everything, but I did have a meeting with Teodros last week and kind of updated him on what I'm looking to get out of this and participating. And yeah, so I'm going to keep on coming. I don't know, we're not currently looking for funding. That's kind of way out of what I do. But still, like Gina, wanting to have a seat at the table and see how we could potentially partner, and also just enhance our relationship with the 2 health plans in our county.
So Andrea, that is so once again helpful for us to hear as well. And I do want to give this retroactive apology that the first couple of sessions felt like they were focused on a specific concentration, because as a part of CalAIM, we have noticed that the vast majority of providers that have needed help, your assessment is so accurate, have been housing providers. And I think it's a reflection of the state of the state, not even just the state of the state, but a state of the nation, at large,
for sure.
The crisis that's in front of us, because we want to make sure that every single participating organization has quite literally this seat at the table. And I do remember reflecting on the AIM statement and how we wanted to make sure that the AIM statement didn't just say for those organizations that are pre-contracted or contracted, but for those organizations that are not going to seek a contract, and you network and refer out to or from those respective organizations as well. And so I will gladly follow up with Teddy on just some of the notes that came out of the most recent one-on-one that you held, because a lot of that feedback goes into session design. So when we have those one-on-ones, we hear those needs, and then we really try to incorporate it directly into the content development. And even more so, another takeaway from what you just stated, the organizations that are not at the table, Were you able to like uplift any of those organizations like during that one-on-one? Because if not, I would love to know like who we should reach out to.
I did not. We didn't even get that far. It was more just kind of telling him about the program, some of the barriers that we face in the referral processes, because we know that if a child under 5 is on Medi-Cal, they automatically qualify for the WIC program. But our state is able to provide us data, like our state WIC program is able to provide us data, no participant information, of course, but they can tell us that there's this many thousand people in San Joaquin County who qualify for WIC but do not receive WIC services. But we know that because Medi-Cal data shows that they're under 5 and they're on Medi-Cal, and somehow they can cross-reference those. And so we're trying to get those families onto WIC and trying to figure out through all of these different pathways how to get those information, how to get that information out, how to partner with healthcare providers, and just doing outreach and marketing within our own county with limited funding. And so, you know, we're all here on our own pedestals trying to figure out like how to make our job better, how to serve the population that we serve better, you know, and I'm sure we all have our own barriers to all of that. And so the first couple sessions, I was like wondering, like, am I in the right space? Some of this feels way over my head. The language feels over my head. But our California WIC Association says, like, just keep on attending, like, and I'm not the only WIC director across the state. Almost all of us feel the same way because we are not used to working with Medi-Cal. Yes. Right. So all of this seems like a lot. We have our own language in WIC and it doesn't have any of these acronyms in it. Exactly. And so that's what we've been doing, like directors all across the state, attending these meetings within their counties, so that we can ensure, like, as things progress and move forward, that everyone is aware of what WIC is doing and, you know, how we can best partner. So that's what my goal is, to like just keep on coming, see how this can help improve some of the relationships I have within my own county, to help improve those referrals to our program.
No, 1000%. And I think what's like super awesome, like Andrea, about like being able to like uplift like the specific referrals component is that for the first, like, quite literal, like 6 months of this work, we, like I said, aggregated like so much data and like fed this into the TPA and to DHCS. And like, we're receiving like some of the fruits of that labor. And so like for the remaining portion of CPI, because we're only halfway through, this is just one of those issues that just needs to get reflagged. But then I also have a question for you. I'm not sure if it's gonna be relevant right now in this moment, but I don't want to forget it. Right now with the master data sharing agreement that certain organizations are testing, would you happen to have like held any conversations with those organizations that are a part of that like pilot that are testing that master data sharing agreement?
I have not, but that is like the biggest barrier that we face. And we know other states are sharing this data. And California, I think because of the size, you know, it's just such an issue. There are states that have whole systems where it's like you apply for, you know, food stamps, Medi-Cal, WIC, like all in one application, and then it gets filtered to those programs. And here in our county, you have to apply individually. Actually, mostly across the state, you have to apply to all of these programs, which are very similar, but also very different in many ways. And so, you know, it's a big barrier because we have families getting CalFresh, but not receiving WIC when they're eligible to receive both, you know, and same thing, they're on Medi-Cal, but not participating in CalFresh or WIC. And that having to apply and bring those exact same documents to multiple different locations, multiple different hour-long appointments, like, is a really big barrier for families. And just the knowledge and education and, you know, knowing the services that WIC provides, how we are different than CalFresh and the additional services that we have for them during pregnancy and, you know, early childhood. So all of that is, you know, is what I'm trying to accomplish.
So 2 more like really quick points of reflection. I know I've said this before, like to the group at large, but I just wanted to reflect upon what you said about like just not understanding and like being familiar with like all of the CalAIM language. And then I'm gonna get to Samantha. Not being familiar with all of this CalAIM language. I remember facilitating a conference panel in Sacramento literally last year, like end of year 2022. And when we were uplifting that there were multiple providers that were new to the CalAIM landscape, but did not speak CalAIM language, you know, someone literally said, yes, like it's not just me. So I just want to like really like validate the fact that this is enough for the providers to have to transition into working within a Medi-Cal landscape, let alone like yourself as like an uncontracted stakeholder that is very important to this landscape. So I just want to validate that. Super important to call out. And number two, I think that something that I would like to take a note from on the back end, like for the Health Begins team, is to learn more about the utilization of the master data sharing agreement and figure out like, is there a pathway like for WIC participation? Because I know this is something that has been uplifted previously, not having to reshare the same data set multiple times, just being able to make sure that this individual or member beneficiary qualifies for multiple services, like with the provision of like information one time is like a goal. And if California can do it, anyone can do it because of the state size. And then I see from John, there's a question. It says, is there a referral form for WIC? We come across families, but only provide numbers.
Yeah, so that is a barrier. So there's 84 WIC local agencies, and in San Joaquin County, we have 3 different WIC agencies where we all basically do the same thing, right? But we're run by different parent organizations. And so with that, there's a lot of silos that comes because the state does not provide this one-stop shop. And so we have an online application at cmcwic.org that participants can apply online, and that goes directly into our inbox and we reach out to them. I think the state is working on an online application. You can go to the state WIC website and like put in your area code and get a list of agencies within your area, but it still puts the work on the participant to complete. And so, yeah, that's, you know, we have paper handouts or paper brochures. I mean, I'm not sure anybody wants paper anything these days. But like within the doctor's offices, they have like pediatric referral forms or WIC prenatal referral forms, and they'll complete it and send them over to us. But the best way currently for us is the online application for WIC participants. They can still call, but I think it's better service when they apply online and then we reach out to them. But yeah, they can walk in, they can call or complete the online application.
And I know our time always goes by so incredibly quickly. That 25 minutes is almost up. We have about 3 minutes left, y'all. John, did you have any feedback for Andrea? I know that you have done a lot of referrals work, like building up networks in your region. And I saw you came off mute. So did you have any feedback?
Oh, I was just going to say thank you for providing that information. But I do have an opportunity to say, hey, if you come across any families that are at risk of being homeless or that are homeless, we are providing community supports for a lot of CMC members, since they're only providing enhanced care management support. We get a lot of referrals from the ECM team to us for CS support, and we're doing housing support. So we do housing navigation, housing deposit assistance, and also housing sustainability and tenancy support. So if there's anybody that you may come across, we might develop some type of a workflow process where we can communicate where your families can be referred directly to us, especially if they're having Health Plan of San Joaquin and HealthNet.
Yeah, that's great to know, John, because we feel helpless when there's housing issues. And we actually have we have one assessment question in our family assessment, and it asks, I think there's 2. One is, are you concerned you may not have housing in the next, within the next 2 months? And there's another one related to housing, and we feel that we've been told there's no resources and that people are on wait lists for years. And, you know, so it feels helpless to us to be able to tell them, like, this is what we hear. because we don't really understand what is happening in, you know, the housing, with the housing crisis, even in our county, because we say like what we hear is there's stuff available and then there's not, and then now there's a waiting list for 2 years. Like, you know, we're hearing all of these different things. And so we do feel really helpless when it comes to that.
Perfect. I'll reach out to you if you ever want to do an in-service where I can educate your guys' teams on the information that we provide. Okay,
I would
perfect.
love that, John. Thank you.
I also have a question. I know that we are closing in about 40 seconds, but Andrea, I really hate to shift burden, because I know that's something that providers and like just supporting organizations have been discussing, like not putting all the burden on you. But in the interim, is that also something that's happening in the reverse, like an in-service with like the providers that have been like on the calls for SJS for San Joaquin and Stanislaus, like on behalf of like your office?
I don't really quite understand what you're saying. Is there CMC representatives on this call? Is that what you're asking?
No, actually, because we're going to close, I can offline with you about that question, because John just made a light bulb go off for me. Whiplash.
Welcome back. All right. How are breakout rooms? Quick facial or emoji reactions. Hey, we got a thumbs up. We're getting smile from Jose. We're getting party from Alexis. Thumbs up from, excellent. We had great breakout rooms. Good, good. Homework between now and the next meeting is to really move the next stage of your PDSA. So for folks who are in the planning process, to move towards doing. For those who are in the study process, looking at whether this will become standardized, do you want to continue it? Office hours are available to talk about this. You know, those of us from the Gash Out group and Health Begins are available to get on one-to-one calls to talk through this. So absolutely no expectation that you figure this out alone, but we do want to be figuring this out and making progress together. All right, next slide. Next steps, very lovely picture of steps there. Next slide. All right, final poll. Which part of today's meeting was most valuable to you? And you can select as many as apply. Casey had to jump off early. He would have been so appreciative of being able to pick more than one. But which part of today's meeting was most valuable to you? The DHCS statewide policy updates, planning an in-person event, the children and youth population of focus, or the barrier busting that we did together in small groups? Great. So the DHCS updates were helpful. I also know in our poll last time, people found that really helpful. So this is certainly a theme. We're getting these updates broken down. People are finding helpful. People got energy for the in-person. We love it. Thank you for completing the poll. Next slide. Okay. So next month's session, we will do a follow-up email in registering for the September brunch. Please use the link that's provided in the follow-up. I'm going to skip number 2 for now and go back to that one. We already talked about homework. Let's keep making progress on the PDSAs. Office hours. The next one is August 17th from 1 to 2. You can use the link that's there in the slide deck to join the meeting. They're very, very helpful. People have really appreciated them. So try to make time for that. Again, you'll be able to access materials through the shared project folder. If you have any questions, Shiva is incredibly responsive. And want to let you know about a new opportunity for grant funding, which is about the data exchange framework. Next slide, please.
I'm sorry, Shiva, we can actually go back 2 slides. I'm sorry about that.
Oh, sorry.
Yes, to Krusty the Crab.
Thank you. Crap. So another round of the California Health and Human Services Agency's Center for Data Insights and Innovations, say that 3 times fast, is open and accepting applications through September 1st. So you have a month. It's $47 million in grant program, which will provide support to entities that have signed the DSA. So there'll be resources to address critical operational, technical, and technological barriers to the implementation. And folks that are not eligible for TA Marketplace or cited funding may be eligible for this. So please don't assume that you're not eligible. We did not have time to bring an analysis of more details for you about this grant, but it's certainly something you can ask more about at office hours, or of course, always feel free to call or send an email. All right, I think that's it. We made it through. Much appreciation for all of you. Have a wonderful day and try to keep cool in this crazy heat. Bye, y'all.
Thanks, everyone.